The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hello, ladies and gentlemen, and welcome back to the FlightBridgeED MDCAST. I'm your host. My name's Mike Lauria. I'm an emergency physician, EMS physician, critical care physician, and very, very passionate about critical care transport, and currently working actively as a flight physician and doing critical care transport medicine. This is part 2 of an episode that I did with the illustrious Dr. Jeff Jarvis and trauma anesthesiologist from UT in Houston, Dr. Chris Stevens. We talked about managing airways in profoundly hemodynamically unstable patients. Again, we went down the rabbit hole on this one, so we divided it up into 2 parts. As a brief review, in part 1, we kind of went over the whole point of why we are using medication-facilitated intubation, with a focus on this balance and this challenge we have between making sure people are not aware that we're giving them appropriate amnesia, but not giving them so much sedative that we're actually affecting their hemodynamics. And that is a very delicate balance. And that brings into question how we even define what a crash airway is. So when we have to very carefully consider these things. And then we talked about the very nuanced and complex decision-making in the pre-hospital environment when we have to get to the trauma center. Do we intubate this patient now? Do we do it in flight? Or do we not do it at all if we can adequately oxygenate and ventilate these patients with less invasive interventions? So we kind of talked about that decision-making process. And then we always say, and the conventional mantra is resuscitate before you intubate. But what does that mean, especially along the timeline of moving this patient from a scene to a trauma center? What do we actually mean when we say that? And in particular, what are we aiming for? What are our oxygenation and hemodynamic goals for this patient before we actually push medications on them? So that's kind of what we talked about in episode 1. Or part 1, and now we're going to begin part 2. We're going to start off by talking about pressors in trauma, which was for a long time a very controversial topic, and now we know that is safe and reasonable and is common practice in trauma centers under certain situations, and making sure that they're also appropriately resuscitated with blood products. We talk about mechanical ventilation, talk about positive pressure ventilation, both with the BVM and a ventilator, and why that's a really important consideration for these patients. We also go on to talk a little bit more in depth about some of the pharmacology of some of the paralytic agents, specifically Rocuronium, some considerations there, as well as the very, very controversial topic in the world of pre-hospital emergency medicine and also critical care about potentially going lower on the doses of some of those medications and some of the evidence behind that. And then also considering in some patients that are peri-arrest or profoundly hypotensive and also completely out of it. So like our GCS3 patients, perhaps they don't need sedative medications to make them forget. And again, that is incredibly controversial in some specialties, but is common practice in trauma anesthesia, and is something that we want to at least remain open-minded to and consider there's equipoise for this conversation at this point, and we should at least be discussing it. And then we go on and talk about some of the more nuances, some of the more nuanced nature of administering Rocuronium, including things like what happens when it doesn't work, or at least it appears to not work, and the expiration date on that medication, as well as being aware of the pharmacokinetics and pharmacodynamics and understanding why it is so important to wait the full minute for that medication to take effect. So without further ado, this is part 2 of Crash and Burn, managing airways in hemodynamically unstable patients.
It really is. It's an assessment of risk versus potential reward. So I think that if you think you're going to hold off on taking an airway because you think your judgment, given all the evidence, is that the patient will continue to oxygenate and ventilate well, they'll continue to protect their airway en route. And let's take your scenario a little bit further, because I think the involvement of your brain really matters. So if the patient has a TBI and is hypotensive, let's say they have multiple injuries, we know what the consequences of hypotension and hypoxia are for TBI patients. We also know if they're hypotensive because they ain't got no blood, they need blood. And you may or may not have that blood, or you may or may not have time to fill up the tank with blood if you have it. So my argument for that is if you determine that they are likely to maintain their airway, I have no problem giving it a shot. And I guess the key thing here is if you're en route, you're up in the air, and then determine, well, shit, I was wrong. Now I have to take the airway. That situation, I think, is optimal for dropping a supraglottic. I don't think in the majority of circumstances that you should intubate that patient. We know intubation takes longer. We know the success rate is lower, and we know supraglottics work, particularly temporarily. So in that situation, I would say absolutely drop a supraglottic, get them to some place where you are now in a better lit environment, have more resources, and then you have better pre-oxygenated the patient, better prepared them for ultimate tube exchange, which may or may not be easier than the initial intubation.
Oh, awesome. Great point. So highly depends on the situation. It may very well be reasonable to continue to do some really good, less invasive airway management, or even consider a supraglottic airway. And that, like we said, depends on a lot of factors: crew experience, distance from the hospital, hemodynamics, setup of the aircraft, and do you have the ability to manage an airway in flight in your particular aircraft, which is shockingly not always the case. So yeah, very interesting. So let's talk about that other piece, which we kind of alluded to here. And I think everybody's on board with. The mantra has become resuscitate before intubation. So there's many different perturbations and pithy little sayings that go hand in hand here. But I think we're all on board with that right now. That it's not just, hey, they come with a low GCS, give them a slug of etomidate, sucks, and put a tube in, and then go from there. Especially in our trauma patients. So let's talk about this, because this is what I love to. Yeah, this is the gray, muddy area of resuscitation, right? So what is enough or optimal hemodynamics to consider intubating someone? And I ask this because it's come up a number of times, especially pre-hospitally and with the aircraft. If I'm in our trauma bay, I could jam them full like a massive transfusion. I got all sorts of tools and tricks and things that we can do, right? But in the field, I got maybe 2 units of plasma and 2 units of red blood cells. If you're landing in some rural county with the assistance of 2 very well-meaning EMTs or an EMT and a law enforcement officer, you may not have lots of help. So what would you gentlemen say, if we were going to secure this airway, is a reasonable blood pressure or other hemodynamic surrogate to aim for before even considering giving medications to sedate someone? Chris, what are your thoughts?
This is a great topic and a great question. I think that, every patient, of course, is a little different. It's hard to kind of generalize this depending on, if it's, multiple shooting or car crash, but if they're head injured or not head injured. But I think we could all agree that optimizing them to a point where we don't think we are going to get dangerously low after placing plastic, between the vocal cords, And if we have blood or if we don't, not everyone has blood products. That would be ideal if they are bleeding to optimize them. I think we all agree that whole blood or PRBCs and plasma, if we can get that initiated early enough to improve preload and cardiac output with our push dose pressor at the ready, and get the hemodynamics at least, most people will say a systolic at 90 would be a great goal to go to. And I think I agree with that. If we could get to that point, that's fantastic. I think with blood products and push dose pressors, we can get into the 90s in systolic blood pressure. But other services that they don't have blood and they only have fluid boluses, it may take a little longer, but they should at least have some push dose pressure that they can at least temporize them until we can optimize that preload. But that's kind of my answer in a nutshell. I think just if we can get systolic blood pressure at least in the 90 to higher level with initial resuscitative efforts, then I think it's relatively safe to use a sedative and a paralytic to secure that airway with an endotracheal tube.
Awesome. Jeff, what are your thoughts, sir?
So I have pretty strong thoughts about this, but I want to preface this with saying my strong thoughts are based on pragmatism and my situation. So what I'm talking about here is predominantly ground-based EMS. I think for the most part it applies in the helicopter also. I don't want to try to make this apply. I'm not talking to you hospital providers, not talking to you. I'm talking about EMS. So I deeply, deeply believe if we're going to intubate, we should do it right. And if we can't do it right, we should not do it at all. And I am okay with the not at all part because I think the modern supraglottics are reasonable and effective airways for this circumstance in the context we're talking about. So my protocol on this, and like Chris said earlier, I like the fact that he just very quickly said, okay, we're talking about adults. Hell yes. That's what I'm talking about. We don't intubate children at all because it turns out we suck at it. And thank God we don't do it very often. So, it's supraglottics for them constantly. Now, for adults, what I say is you can either optimize the physiology, and my definition is pragmatic. It is you have to, and I don't know this is right, by the way, it is systolic greater than 100 at the time that you're pushing the drugs and an SpO2 greater than 94 or greater for at least 3 minutes before you push your paralytic. I had to pick numbers. Those are the numbers I picked. What I worry about is not an oxygen saturation of 92. Obviously, I would love to have an oxygen saturation of 92. I worry about an oxygen saturation going from 90 to 40 in 30 seconds and not being noticed. I don't worry about a blood pressure of 98. I worry about a blood pressure of 70 that happened within 2 minutes from the last cycle. So I had to pick numbers. I'm pretty happy with the oxygen saturation number. I would much prefer to ignore the damn saturation and look at an end-tidal O2, but we don't have that. So what I'm left with is a time-based parameter for oxygen, and picked 3 minutes because that's about as good as you're going to get in the literature. I picked 100 because it seemed reasonable, and it's easier than shock index. I will tell you, when we just rolled out intubation DSI here in Fort Worth, and our measure that we were building our improvement campaign around was -1A. And what we're finding is hypoxia, we're not seeing issues with hypoxia. They follow the protocol, and hypoxia is just not the issue. Post-intubation hypotension is the issue, even in patients who are not hypotensive to begin with. So I am likely to actually increase the systolic blood pressure threshold because I'm just now going on the assumption that they're going to be hypotensive after transiently after that intubation. And I'm trying to prevent that. I have no idea what the right number is, but I'm certainly not going to lower it past 100.
Gotcha. Okay. So we got a 90, we got 100. I'm going to put my protocol at 95, split the difference.
95.23.
Yeah,
exactly.
That's right. Yeah.
And have exactly as much science as either one of us have for ours.
That's right. That's right.
Two other things that we've kind of hinted at, one in particular. So this one, I'll start with Chris again. So, Chris, I've heard from some of our colleagues in the dogma and the pre-hospital and emergency medicine world sometimes that they're trauma patients, man. They shouldn't get pressors. They need blood and fluid. You got to fill the tank. Can we give trauma patients pressors? Can we do that?
Yeah, don't say this to anyone out there, but that's what we do in trauma centers. I tell people all the time, I think, it's a little different. I think that, and it may be a little different everywhere around the country, but I think, in the 20 years that I've been doing trauma medicine, I think that, pressors have always been part of our world in anesthesia. We use them readily. They're always right next to our side. We draw them up for pretty much every single case that we do. We're just so used to using them. And when I say use them, I mean to temporize, right? I'm temporarily using this to bump the pressure up so I can get another IV established, get a central line in, start resuscitating more, hang colloid, a bolus of crystalloid, whatever the case may be. And I think, and again, data aside, we're not talking about data here or literature, but, just practice, the art of medicine in general. I think that it's critically important that we consider the use of temporizing with vasopressors, even in the trauma patient, until it buys us a little bit of time. If they're requiring push dose pressors and blood, they are going to become catecholamine depleted. It's not going to take them long. And I think people have to remember that you only have a reserve amount of catecholamines. And when you become catecholamine depleted and you're starting to get hypotensive and you are losing your ability to compensate, we have to give them those catecholamines back to temporize until we can start getting them fully resuscitated. There's no, we can't put a cordis in someone in the field, right, and rapidly give 2 units of whole blood. It's not going to be that fast like in the trauma center. So anyway, that's my take on pressors. I think there is a role for them in trauma patients. I think it's an important role, especially if we have a combination head injury and hemorrhaging patient.
Agree. And
we got to maintain that cerebral perfusion.
Got to throw this out there. Push dose press of choice, phenol, vaso, epi in trauma. What you reaching for? Whatever's available.
You're giving that option. I mean, of course we're going.
Yeah, I know. Yeah, I mean,
you got to make him choose.
They're all different, right? And they have different mechanisms of action, right? You got to look at the pharmacology. But I think our go-to, at least in the anesthesia world for trauma patients, is either norepinephrine pushes or phenylephrine pushes initially, right? While we still have some type of blood pressure, right? We've got some perfusion, looking at our end tidal for perfusion, looking at our SpO2 waveform, and looking at our blood pressure until we get arterial invasive line in. That being said, if they are peri-arresting, then they are getting epinephrine, period. And I'm very adamant about that. We use epinephrine in traumatic arrest in the trauma center. And if people say that that's not, then they're lying, because that's the drug that gets used. If we're in the operating room and that patient is literally losing end tidal and we are losing pulses, they're going to get code doses of epinephrine while we give them more blood product, because they are catecholamine depleted at that point. They're vasoplegic. They don't have the cardiac contractility. Their catecholamines are completely gone. So we have to do something for them.
Absolutely.
And so, yeah, that's what we do.
And I think that's you made a very important point there, Chris, which is as a bridge to blood, a bridge to get you there.
Yes.
Because in reality, yes, it's not the solution, but the kinetics of how these resuscitations unfold, especially on the side of a dark New Mexico state highway, or dare I say a Texas state highway, is very different than the inside of the trauma bay. Jeff, what do you think? Do you have push dose pressors in your guideline for RSI, DSI?
Absolutely. Not only do we have push dose, we have epi infusions and norepi infusions. For this purpose, it's typically a norepi infusion. We don't carry phenylephrine. Just, added drugs. It seems like for a lot of patients that might be a nice option for them, but we don't carry it, so it's not an option. And the thing that I love about, I do want to come back to epi in traumatic cardiac arrest, because I think when you're having that conversation, again, the population and the settings and the context matters. So in the EMS context, when I hear people say, first off, if the word pasta water comes out of their mouth, I'm going to twitch. It's not because I necessarily disagree with them, but because by saying pasta water, you're oversimplifying things and you're rapidly going towards dogma. And I just sort of lose you. When I get told a lot, don't do anything other than blood for hypotension. And by the way, don't let your patients with TBIs get hypotensive.
Right. Yeah.
I don't have any blood. What do you want me to do? Well, don't let them get hypotensive and, don't give pressors. That's not helpful advice to me.
That's all I got, man.
I do have a way to treat their hypotension, but you're telling me not to do it. So I'm just going to stop listening to you because you don't understand my environment. I am absolutely going to give them pressors. So we do it as a bridge, particularly the push dose. Usually our push dose is just a bridge to the only other thing we have, which is a continuous infusion. Yeah, that's not what they need, but it's what we got. And it does raise blood pressure. Yes, it's working. You either want me to let them have a blood pressure of 60 or you're going to let me give them pressors, because those are the only two options. This is just a pragmatic world. I would love to give them blood. I'm working as hard as I can to give them blood, but we ain't got it right now. The issue
your system just can't pull it out of the air. You don't have a blood bank that will just produce units and units of whole blood and give it to you. Put it on every rig, pay for the refrigeration and the everything. No,
I'm going to invoke the thumper rule. If you can't say nothing nice, don't say nothing at all. In progress.
This is a great state of Texas, though, sir. I mean, I just assumed. I guess I assumed wrong.
Well, let me put it this way: our holdups are not regulatory.
Very good.
The issue of epinephrine that I wanted to talk about in cardiac arrest, I think if you are in a resus bay in a trauma center, that traumatic arrest is different than if you're on the side of the road. And the reason I say that is in a resus bay, you have an option to get very aggressive and get hemorrhage control. We don't have that option in the field. If they're in a traumatic, clearly we're not talking medicine here, although I'm happy to have the what to do with epinephrine in medical arrest too. That's a fascinating discussion. But here, epinephrine is a temporizing measure, but it ain't going to work enough to get them to a trauma center. So I think we either need to fix the problem or we need to admit futility and not transport. So do the things that you have available that might work. Decompress the tension pneumothorax, decompress pericardial tamponade, fix the airway obstruction. That's the problem. If you have blood and feel like you can, there's a cost benefit with blood because it's a precious resource. If you're going to use it in traumatic arrest, by all means, use it. If that doesn't work, then you're probably not going to survive, and the risk of transport outweigh the benefits of transport. So in that case, I'm not sure epinephrine has a role. If I have the opportunity to fix the problem surgically and I need to buy time to do it, then by all means do it. So I think context is important.
Yeah, I do. I agree. And I wanted to reiterate that too. I think, I was mentioning about patients in the operating room or in the trauma bay, and we're going to rush them up to or whatever. Well, that's a hospital situation. But absolutely, if you're already transporting and they are peri-arresting, and then that's, I think, would be a time, hey, that we're throwing the kitchen sink at them now. We're already transporting. We're kind of, the train's left the station. let's just give them everything we got and hope for the best. At least we can go to bed tonight saying, hey, we did everything possible for that patient before getting him to the trauma center.
Yeah, and what's
that's a really
just
fair point,
unfortunately because of laws and expectations and culture, once they're in the truck, you're going. It's really, really hard to terminate an arrest in the back of the truck.
Yeah. I think one of the other things that I wanted to run past you, gentlemen, on the topic of resuscitation or peri-airway management resuscitation, and this one always gets me, man, and is one of those practical confounders. I've definitely had patients very sick trauma patients that are super hypotensive. They get an appropriate amount of drug, whatever that is, and then a little bit of push dose pressor, and then tube goes in just fine. First pass, 30 seconds, 40 seconds, beautiful. And then a very well-meaning associated healthcare provider gets on that bag and positive pressures through the moon, and all of a sudden their blood pressure drops, shockingly. So
nobody could have
you,
predicted
gentlemen,
that, Mike. Nobody could have predicted.
Yeah, this never.
Yeah, never happens, right? Never happens.
Mike. I don't know.
Adrenaline.
This never happens.
And I'll be the first to admit I've done that on the side of the highway. I've done it in the ICU. Adrenaline's pumping, and I really got to take a deep breath and back off that bag valve mask accelerator there. But it brings up, I think, two interesting points, right? One, a confounder, significant confounder, especially if we're talking about medications and peri-intubation hypotension. Was it, if it happens within a minute or two of each other, like, is it the meds? Is it the positive pressure in their chest? I don't know sometimes, but I'll start out with you, Jeff. For hypotensive patients, specifically patients in hemorrhagic shock, how do you tell your crews, like, they have been intubated, you've successfully managed the airway, how do you manage them with a BVM or transition to the vent if they're a flight crew?
Yeah, I think the first thing I let them know is, by definition, you're going from negative to positive pressure ventilation, and you need to understand what the consequences of that are. If you have low preload and you still have negative pressure ventilation, you are augmenting that preload every time you take a breath. As soon as you paralyze them, intubate them, and put them on a vent, whether it's a manual vent, whatever the issue is, they're now have positive pressure ventilation. They're losing that extra pump, if you will. Just assume that they are going to become hypotensive. And if you're wrong, that's the way I like to be wrong. So just assume that it's going to happen, and understand that you can make that problem worse by increasing your rate, increasing your volume, increasing your PEEP. And like all things, try to use only that which is necessary to achieve your goals. So the key thing I stress over and over again is understand it's going to happen. If it doesn't, this is great. And the other thing is, you mentioned you're guilty of doing it. Well, you're guilty of being human. This is a human issue, and all of us are going to do that. The only way to avoid it is with a vent. But, a lot of us don't have that. We certainly don't have it on all of our trucks yet. So just understand it's going to happen. It's like, how do you deal with anchoring bias? The only way to do it is be aware that it happens and watch out for it.
Gotcha. So it sounds like we need to come to Dallas. Chris and I can set you up with your own blood bank to give you whole blood, ventilators on every truck, and a field thoracotomy protocol, right?
So just to be clear here,
That's right.
This is in my contract. If you are from Texas, you understand this. Chris knows exactly where I'm going. It is in my contract I have to correct people if they say I'm in Dallas. I am not in Dallas. I am in Fort Worth.
Mea culpa.
We are the normal city.
That's right.
But yes, I will take your whole blood factory and your vent factory. I will take it. Bring it.
Cool. To Fort Worth.
Fort Worth. Dallas is on their own.
And you guys have been pretty good about New Mexico. No one in our circles has referred to it as Mexico. So I feel like I've just shorted the community of Fort Worth. I'm sorry.
How could I say anything about the land of enchantment? You have a beautiful state, man. My only problem is that I did an away rotation in Albuquerque, really wanted to match there, and I said, nah, I got to rank it down because I do not fit on the cover of Outdoor Life. So I clearly don't meet the qualifications. No, you live in a beautiful place.
I do. I take it for granted sometimes. Chris, positive pressure in post intubation for these patients. What do you tell your air medical and also your ground crews of how to bag these patients or manage them on event after intubation?
Yeah, we're pretty lucky. Both of my agencies, ground agencies here, have transport ventilators now, and of course our air medical as well. So we try. What we've been teaching them is, safely get the airway, safely start using hand ventilation techniques with low tidal volumes. Not that we teach them how to bag. We even went to the small adult BVMs at one of my agencies just because of the interest around the country on doing PD BVMs versus adult BVMs. And anyway, we've had, I think, some success with it. I don't think it's a earth, shattering game changer. But one of the things I remember about EMT school is our airway lecture was so critical, to our outcomes with being a basic EMT, managing that airway with basic skills. And this is EMT. What we teach, this is EMT level skill that the paramedics have to pay attention, and we have to train our basics and the people helping on the ground on how to gently, we call it gentilation in anesthesia, which I always laughed at that term, gentilation. But
I love that.
Gentilation. It came from ARDS. Yeah, gentilation. So I had a professor that taught me that, and when we were talking about ARDS and rounding in the ICUs, and he said you have to use gentilation. We're like, gentilation? And he said, yes, low tidal volumes, low rates, low tidal volumes. Permissive hypercapnia is okay. We're not talking about the head injured patient, right? We're talking about your standard patient that's intubated. But I teach them, don't get aggressive on your bagging. You have to do a little bit of chest rise, barely squeeze the bag, get SpO2, get your end tidal, and we'll get there. But I like to get them on the transport vent as soon as possible because we want to target that lower tidal volume. Target that lower tidal volume and start that rate and that low PEEP. And let's wait until we get vital signs, get our hemodynamics squared away, get our resuscitation going. And it's okay. We will get to the ventilator. We will make adjustments, but we have to focus on the resuscitation and the hemodynamics, I think, before we start delving into the respiratory care, because that, as transport ventilation of a patient takes time, right? It takes time to fix it. It's not going to happen in a 5-minute flight to the trauma center. Just oxygenate them, try to target your end tidal, and we'll take care of the rest, eventually.
Gotcha.
Chris, I have to warn you, I am stealing the hell out of that. I was writing it down. Even as we were recording. I love it.
Gentilation. Take it. Yeah. Take it and run with it. That was from UTMB. You can use it.
I like that.
ICU, John Seeley ICU round. Yep.
It sounds like the great title of a podcast to come. Gentilation.
Gentilation. Absolutely.
All right. So now let's get back to our scenario of this poor gentleman who got hit by a car. And let's say your organization does carry blood. Say 2 units of reds, a couple units of plasma. They do a great job. They get a couple IOs in really quick, start pumping the blood in, actively resuscitating them. And now you've hit the golden blood pressure of 95.2 systolic. And as it turns out, they're, let's say like a little bit trismus. They're hard to ventilate. You can't really maintain the sats. And the decision of the crew is that we probably need to manage this airway. It's a 20-30 minute flight to the trauma center. Getting in the back of the aircraft at 2 a.m. with this patient may not be the best. We're doing all the good resuscitation stuff. Systolic blood pressure 95. Chris, what do you train your crews, specifically your air medical crews, to do in terms of medication selection and dosage?
Okay, so good question. And again, in this particular situation, we're still talking about a GCS level or a depressed level of consciousness.
Yeah, still like GCS of 3 now, like really not doing anything.
3, so really low now, so not responsive at all. Okay, so what I started training our crews to do.
And this is pre-medication, right?
Pre-medication.
This is pre-medication, yes, pre-medication. So if you are a GCS of, we're going to say 3, we're being extreme here, right? By definition, I know this is earth-shaking, but by definition, you are in a coma, a Glasgow coma scale of 3. we give you 3 points to show up to the party, right? So, but you are doing nothing. You were completely unresponsive, completely unaware, in a comatose state. You do not get a sedative. You don't need a sedative. A sedative is just going to drop blood pressure even further, likely, unless we were actively resuscitating with push-dose pressors. But there is no physiological reason to push a sedative at that point. They should get rocuronium. They should get a tube placed safely, vital signs, continued resuscitation. And as the pressure continues to improve, then we will start sedating that patient. And that's what we are starting to teach.
And so that you're actually teaching that to the flight crews at UT then, yeah?
Yes.
Okay. Cool. And a slight variation of that scenario. Let's say they get him a little bit earlier in that scenario when he was still GCS of like 5, 6. So maybe posturing, maybe with deep, painful stimulation, withdrawing, or trismus. What would you suggest at that point?
So again, yeah, in that situation, if the crew has any concern about awareness or recall, then this is a clinical judgment on their part. Then a shock dose sedative is where you teach them to use a much lower dose of a sedative, followed by your paralytic and intubate safely. And then, go off of vital signs and go from there as far as redosing that sedative as you continue to resuscitate the patient. So we kind of look at two different things. We look at, some potential for awareness and then very low potential, if not zero potential for awareness in someone who's completely unresponsive and hypotensive. In my experience at this point, we have not had one patient that has said they remembered being intubated before getting on a helicopter or in the trauma center coming to the operating room when we have done this. So again, I don't have data to show. I'm starting to work on data. We don't do this that often, obviously, but these are the most extreme situations that we're looking at.
Mm-hmm. Yeah, and I think that's one of those hard things to tease out. Because those patients, I think we can all agree, they're is not an everyday situation by any stretch of the imagination, and that is a very challenging hemodynamic conundrum. And there's not a lot of data one way or another. This is someplace that a lot of people have been up in arms at, like, how dare you give a paralytic to someone who you're not getting sedatives to. It's an interesting point, and I think some people have made it that the entire point of sedation was to induce amnesia of the event, to provide for anxiolysis, relaxation, and amnesia. And if those things are not needed, someone who's completely unresponsive, peri-arrest, or our patients in cardiac arrest, we can argue back and forth about supraglottics versus intubation in that population, but in that population, it's not indicated to give them sedatives or paralytics. And in fact, one that's interesting thing is I was going through before this and I was trying to find some data or evidence. I really couldn't, to be quite honest, but the hallowed ground of emergency airway management and the Walls manual actually still has a section where if you cannot ventilate or intubate a patient that's essentially completely unresponsive and meets at least their definition of crash airway, to push a dose of succinylcholine as your neuromuscular blockade without any sedative. This, of course, is highly controversial, but there's, I think, equipoise to consider it. And yeah, so I think that's very interesting. That is definitely different than some institutions and organizations.
Well,
but
as a side note, this is an anesthesia practice. We've been doing this for decades, right? This is we've been doing this for many, many, many years. This is nothing new in our world of practice. Especially working around very sick, critically ill and injured patients in our ICUs coming back to the operating room or re-intubating them in the ICU. And we just, we're more concerned about cardiovascular collapse in these patients, getting them re-intubated or getting their airway secured, than we are about recall. And I do I say this when I give lectures, that I would rather have someone with some recall than a dead patient. And in reality, we see it. In ERs, people die of cardiac arrest every day in this country from RSIing with sedatives in the trauma bays. We see it all the time. It happens, and they chalk it up as well. They arrested. Oh well, I don't. They bled out or whatever the case is. And I'm not convinced that it wasn't the sedative that was partly to blame in that. I've seen it myself in the trauma bay. I've done it myself as a fellow, where I've given 4 milligrams, 2 cc's, 4 milligrams of etomidate and succinylcholine in a patient that was combative with multiple gunshot wounds, diaphoretic, and I intubated them, and I couldn't get an end tidal, I couldn't get a pulse, and we had to do CPR and start blood, get central access, give epi. We got pulses back, and we were able to go to the operating room. But that was 4 milligrams of etomidate, and I'm convinced that I pushed that patient over the edge of the cliff with 4 milligrams of etomidate, and I'll never forget that patient.
So, Jeff, thoughts, sir?
Yeah, absolutely. So you're not probably going to be surprised that I disagree. And just, I want to be clear, because when I talk about this, I like to define my denominator. I am talking about in the pre-hospital environment. And the reason I say that is we frequently, when we get into this discussion, think it's an ET tube or nothing. And it greatly overlooks the fact that we have effective airways that patients tolerate much better, and that's supraglottics. So I have to be dogmatic about some things. And when I'm not dealing with critical care physicians. And this is the beauty when we were talking about, you were talking about Darren trying to talk to you, Mike, about what you're doing in the field versus the protocols that you're writing. I'm not going to tell you how to practice medicine. This is the beauty of going to school for 4 years and then training for 3, 4, 5, 7, 10 years, is that it's a different population of clinicians. One of the beauties of being a physician is independent medical judgment. I'm not trying to tell you how to practice medicine. On the other hand, I have a responsibility to set protocols for, I have 1,500 providers, about 500 paramedics, and those are not, and they are wonderful human beings, and they make outstanding clinical decisions every day, but they are not practicing medicine independently, and they don't have the same skill set, and hell, they could have the same skill set. It's not about the skills. It's about the knowledge base and the decision-making capacity that you do. So my protocol, and I'm not trying to say what anybody else should do, but I do not allow people, it is an absolute, you don't give a paralytic without a sedative. If you think they need a paralytic, then give them a sedative. If you don't think they need a paralytic, I'm fine with that, but you're not going to intubate them. You're going to do a supraglottic, because I think that is a very effective temporizing measure until we can get them into an environment that has higher trained people with better decision making, better equipment, better environment all the way around. And we have delivered you a patient that is now better prepared for whatever you're going to do. So that's my take on it. I don't think we should be doing this pre-hospitally, but that's my take, and I try not to judge what other people do.
I think there's two things there. Go for it, Chris. Go for it.
I was just going to say, Jeff, I agree with you completely because of the agency. I think we need to talk about just comparing a large ground EMS agency, Houston Fire Department, for example, Dallas, you name it, wherever you are, your practice and your protocol is going to be different, right, than a flight crew or a highly trained, small ground-based ICU level trained crew. And so I think we got to be, just mindful that, when you, like, one thing I remember learning in my EMS fellowship, the first lesson I learned was you see one EMS agency, you've seen one EMS agency, right? So you can't compare my agency with Mike's, with Jeff. So I think it's hard to translate some of these protocols and practices, and that's the beauty of EMS, right? It's every agency is a little different. So I agree with you, Jeff. And your agency, very different. So I agree with you. For your system, absolutely, it's going to be a different practice.
So I will tell you
that
my opinion hasn't changed since I left Williamson County, where I had 100 paramedics, and I could really train them better. And it didn't change from when I was a PHI medical director with critical care paramedics and nurses. I still feel that way outside of a hospital where you're not dealing with physicians. And I tried desperately not to do this in the emergency department. I just am not in the business of dictating other physicians' practice. I am, by definition, am in the business of dictating paramedic practice. So that's what I try to limit myself to.
So let me ask you this then, Jeff. If you had that patient, right, your crews did an awesome job. They got access. They've been doing less invasive airway ventilation. You got the blood pressure up to 95.2 systolic. But they're now running into issues with secretions. Maybe the trauma patient's vomited. You really are concerned about their airway. And the crew thinks that I need to give them a neuromuscular. I should paralyze this person and put it in a tracheal tube. What medication and then what dose?
You bet. So this is really interesting because our protocol right now is 2 per kilo of ketamine and Rocuronium, 1.5 per kilo of Rocuronium. And I mean, I'm more than happy to get into the details about the protocol, but it's essentially a DSI for everybody protocol. If you need to give pressors to get the blood pressure up to safely give them sedatives, do it. I would honestly rather give them sedatives or paralytics. Let me try this again. I would rather give them pressors to allow them to tolerate the sedatives. That's what I was trying to say. Than give them paralytics without the sedatives. If I had blood, I would absolutely prefer to, assuming that blood is the problem here, I would rather give them blood to allow them to tolerate the sedative. So that's what I do. If they don't feel like they can tolerate it, or for whatever reason, the physiology, there are some patients we can't get the blood pressure up on. Some patients we can't get the SATs up on. I get it. No matter what you do, just don't intubate those patients. Use a supraglottic. And then we will, it's a temporizing measure until we get them to a place where you have physicians, you have better lighting, better environment, better options. And I think we will have prepared them better for whatever it is that's going to happen in the ER.
Gotcha. All very, very excellent points. Any closing comments, gentlemen, on crash airway management, peri-arrest airway management, super sick, critically ill airway management, or any other airway management for that matter? For our
I want the blood that you have to offer. I want that, and I want a damn channel blade that records. This is what I want.
The wish list, the wish list from Fort Worth, Texas, ladies and gentlemen.
Exactly. Absolutely. And throw in some ultrasounds since we don't seem to have a problem, and maybe some T1 vents too.
Nice, Chris.
One thing I do want to mention, and this is a huge point to make for everyone listening. One of the things I've noticed, and y'all may have noticed this too in your agencies, when we're training pre-hospital providers to safely use paralytics to intubate a patient, one of the things, and I have to get on my residents in the hospital about this too, and I'm sure you have as well. When you push a dose of Rocuronium, how long do you wait until you scissor the mouth open and put the blade in the mouth? How long are you teaching people to wait? And it's a long time, a lot longer than you think.
My answer, and this is built into our protocol, and by the way, I don't trust your judgment of how long it takes. There is a stopwatch in the kit.
That's what we do too.
Yeah, and it's 90 seconds.
Yeah.
We go for 90 seconds.
60 to 90 seconds is kind of the textbook answer for RSI dose of Rocuronium. But you'd be amazed. And I would love to do a study on this, and a whole nother topic, but I think body cams are going to slowly start leaking around the country. When we start getting body cam footage and we can time how long till they push the medication until that blade goes in the mouth, that's going to be some outstanding data. But one of the biggest failures in the field of first pass success is they don't let the medication work. They're fighting against themselves. They 10, 12, 15 seconds, they're opening that mouth and trying to put the blade in.
Yeah.
So that's a point I wanted to make for everybody is please let the drug work. You got to start a timer and wait for it to work.
So Chris, the reason that I got to 90 seconds is this was at my prior service, and we were doing DSI protocol with 3 minutes of oxygen. You've met your oxygenation goals. This is post ketamine. Then push sucks, and there were no timers involved. Push sucks and then intubate. And our first pass success was, I don't know, it was 90-ish%. And then we couldn't get sucks. So like a back order, it's just not available. So I'm like, well, the truth is I probably should have been using rock anyway. Now's as good as time as any to go ahead and switch. We'll switch. First pass success plummeted. And I'm like, what in the hell? Every piece of literature I've ever seen, my practice is that it either doesn't make a difference or rock is better. What the hell happened? And as I went into case review after case review, they're intubating at about 30 seconds because their internal clock is stuck on sucks.
Sucks, exactly.
And
yep, that makes sense.
So what I teach people about this is, I think if you look at the kinetics of rock, I think the half-life or the duration for 50% of the population somewhere around 45 seconds. So I doubled it. And said, so what's the downside if we intubate before this patient in front of us is fully paralyzed? Well, we decrease the odds of success. Okay, well, that's the whole point of giving rock. What's the odd? I mean, what is the downside if we wait too long? Well, they're apneic. Well, damn if we don't have a solution for that problem.
Right. Yeah, exactly.
And they already have a two-handed seal with the BVM just for pre-ox. If you got to give them gentilation, then give them gentilation, but wait 90 seconds.
Yes. And that's exactly what we teach too.
Yeah, I was going to say, I think that's absolutely key. And now that we have both the coin term gentilation and some evidence, I think that shows that it is safe and reasonable in some patients. They don't need to be completely apneic, hands off the bag. That it's reasonable to gentilate patients during their apneic phase, not jamming on the bag, but gentilate them. Then I think that's absolutely even more of a reason why we really should be convincing our pre-hospital teams, hospital teams, everybody that you really got to wait.
I think two other points that I want to bring up about this. One reason I have no evidence to say which is the most common reason rock doesn't work. In other words, you don't get optimal intubating conditions. I'm going to go out on a limb. Number one reason it doesn't work is it didn't get there. Your IV's blown. But aside from that, you didn't give it long enough. And then the second reason is you didn't give enough of it. So there's paper after paper. Okay. Well, at least two that looks at the association between rock dosing and first pass success. So 0.8, 0.9, 1, 1.1, and I think they said 1.1 or greater. And the more rock you give, the higher your first pass success. So you may be able to get by with less rock, but for the most part, there's not a downside to more rock. Now, I mean, I don't want to drown them with rock, but I like even numbers. The math is easier, and that's the reason we opted for 1.5, even though that's not in any of the literature that says you should give 1.5. It's a round number. I know you're making up their damn weight anyway. So I'm going to use that. It's pragmatic, and I would rather give too much rather than too little.
No, that's a good point. I agree with you completely. Higher is definitely better than lower. I'd rather have more paralytic than less. Absolutely. One of the other reasons, though, especially we see it more probably on our ground base than air, is it's supposed to be refrigerated. We take it out. We see this in the hospital, right? It sits in our drawers. We use it. Sometimes it doesn't work as well. It denatures once it starts getting unrefrigerated, and it's a slow denature process. But sometimes your rock is bad rock. It just doesn't work because it's not good drug. So I tell folks, if you use it and you got no result at all and your IV is working, then pull another dose out and give it again, right? Because that's something, you may have gotten a bad vial of Rocuronium. Yeah. So that's something to consider.
And that's absolutely a consideration in the pre-hospital environment. We reviewed some cases.
Yes.
And I have personally been a part of one in August time where, guess what? That rock had been out of the fridge for a while. It hadn't been turned over yet because it was close to its expiration date, but not over. And we thought we had blown the IV. We thought we had blown everything. We, as it turns out, switched drugs. We just went right to the sucks. Yeah, that worked immediately. So we basically thought that a lot of it was because sometimes it's just hard to control in our environment and consistently really keep that medication exactly where it needs to be refrigerated. So,
do either of you have any idea what the period of time we're talking about in normal conditions? We're not talking the back of an air conditioned ambulance in Texas, because that's probably measured in minutes. How long are we talking about out of the refrigerator?
Well, the pharmacists that I've talked to in our hospital, they say that a week to 10 days is probably as long as you want to wait to use it. Now, in the hospital, we use it literally like water, day in and day out in the operating room. So we're going through it all the time. So it's rare for us to see it. But out in the field, once it's out in that warmer, and that's cold environment, that's room temperature, cold hospital environment. But out in the field, I'd say probably knock that number in half, and you could start denaturing the Rocuronium. Doesn't mean it's not going to work, but it's probably not going to be as effective.
It's good advice. I like it.
Great point.
And I'm sorry, the one other thing I wanted to say about that. So 4 reasons now why the rock may not work. We keep adding it. I feel like a Steve Martin ad here. The only thing I need is adequate time. Adequate time and enough drug.
That's right.
All I need is adequate time and enough drug.
That's
and
right.
not
denature.
And
this laryngoscope. That's
exactly. We were talking about gentilation during paralysis. And speaking of dogma, there's been the dogma around RSI. The whole point of RSI is so that you don't have to ventilate when they're paralyzed because of the concerns for gastric insufflation and increased risk of aspiration. I think that we overestimate the risk of gastric insufflation and aspiration and underestimate the risk of hypoxia. And I think both are real, but sometimes I think we get it's like thinking you're more likely to die in a plane crash than a car crash. We get the balance a little off. So I really don't want people to hesitate if they are, and particularly for us when we're doing DSI, the odds of them not breathing during this process after they've given the rock, very high. I mean, probably 50% of the population will have ineffective ventilation at least somewhere between 45 and 90 seconds. Don't not ventilate. It's okay to ventilate. Just do it gently with, gentilation.
Yep. Absolutely.
Gentilation. It seems like that's the answer to a lot of our problems now, right?
I like it.
This has been awesome,
blood, droperidol, ketamine, and gentilation.
Droperidol, ketamine.
All I need is
droketamine. Forget the ketofol. We'll just do droketamine. Dopamine. That sounds so much like dopamine. Well, gentlemen, this has been a pleasure. I think we talked about some really great topics. We went over some very important things in terms of the key aspects of safety, but also avoiding things like recall. We talked about our varying definitions of crash airway and airway management and super hemodynamically unstable patients. And as much as I'd like to think we solved the world's pre-hospital airway problems, we probably came up with more questions and more investigations that we need to do than problems solved. So
this is, if I'm ever sitting down to think about a problem, and whether I solve that problem or not, if I haven't created more things to think about, I wasn't thinking hard enough.
Oh, yeah.
Absolutely. Well, Jeff, Chris, thank you. It's been a pleasure. I hope to have you back, Chris, especially as we go over our next podcast. I'm very excited for on gentilation. And yeah, thank you guys very much. Ladies and gentlemen, fly safe out there. Take care. This is Mike Lauria from the FlightBridgeED MDCAST. Take care. Bye-bye.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.